Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on these surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I'm looking forward to our discussion on the recently published article in SurgiColl titled Artificial Intelligence in Orthopedic Surgery Education, a Current Concepts Review. In addition to discussing this article, we'll just do a deeper dive in general on challenges in training surgical residents today. So we are fortunate to be joined by both Dr. Saqib Rehman and Dr. Amiethab Aiyer, both experienced surgical educators. Just introducing both of them briefly. Dr. Saqib Rehman is the senior author of our paper today. He is a professor of orthopedic surgery and the director of orthopedic trauma at the Temple University Hospital in Philadelphia. Dr. Amiethab Aiyer is our guest expert. He is a Drexel Med alum, trained at Hershey and Mercy, and now is practicing at Johns Hopkins University Medical Center in Baltimore, where he also serves as the chief of foot and ankle surgery and is also an experienced publisher and is serving as the deputy editor of the Journal of the American Academy of Orthopedic Surgeons. So very fortunate to have both of you here, very experienced surgical educators and clinicians. I always like to start with some fun stuff, some background so people get to know you a little bit. So a couple things to get going here. One of the questions I have, usually I'll ask this of the authors. So Dr. Rehman, if you don't mind, you're a very accomplished researcher. And so what inspired you to get involved in clinical research in general?
Well, for me, and I apologize for my voice today. For me, it was really just part of the job. I came to Temple and, clinical research was going to be a big part of the job. And honestly, if I had not gone into academics, I might not have done it. So it was really just a responsibility to the mission of the institution where I decided to start my career, and one thing led to another. And, and here we are. I still enjoy doing it and, helping med students and residents, as well as, clinical trials when a good one comes along.
All three of us are academic surgeons, but I can tell you that just working in an academic medical center doesn't mean you're going to be an accomplished researcher. So I think you've gone above and beyond just doing what's a part of the job. So I commend you for that. But Dr. Aiyer, how about yourself? Clinical research, what interested you in getting involved in research?
It's a great question, and I'm honored to be here with both of you today. I'll tell you, my journey into clinical research is a little bit kind of circumlocutic, because when I was at Drexel Med, interestingly enough, I didn't really know what the value of research at that time was, especially trying to pursue a field like orthopedics and sort of what that sort of would lead itself to or lend itself to. But it was probably actually after not matching and spending time with some of the joints folks at Rothman, actually, that I really started getting into research at large. And at that time with Jay Parvizi, it was basic science research with some dabbling into clinical work. But I started realizing what the translational elements of it all were. And of course, residency is just a very chaotic and hectic time. And, I was trying to just, figure out how to breathe and, understand the musculoskeletal world, as it were. So it really probably wasn't until fellowship at Mercy where I started being able to put some of those clinical skills derived from my time with Jay and put them to good work in terms of, all right, hey, let's get into radiographic studies, clinical studies, and some combination therein. And after that, and seeing your name in bright lights on PubMed, on papers, on posters and whatever else, it becomes very addictive, to say the least. And that, I think, not only for being able to optimize and operationalize, patient translational outcomes for patients, but really start moving the needle in terms of what you can afford as whether you're sort of at the outset of your career as a student or even later in your career as an attending, what kinds of differences you can make for your patients. So that was probably a little bit of the way I sort of proceeded with things and why I continue to do it to this day.
That's a great answer. That's a really great answer. And I think when you get involved in clinical research, and there's many routes to it, and I think, mentoring medical students interested in orthopedics and surgical specialties in general, it's often a tool to get to where they need to be. But a certain percentage, I think, start to really understand the value of it and really benefit from it and start to enjoy the process. And it's evident in terms of their work. Both of you are different specialties of orthopedics. So Dr. Rehman is a traumatologist. Dr. Aiyer is a foot and ankle surgeon. What drew you guys to your specialties? Saqib, do you want to go first on that?
Sure. I think for me, it was really like in orthopedic trauma, there's a lot of, you don't see the same thing again and again, right? So I think there's a lot of thought that has to go into preoperative planning and, addressing what, is potentially similar injuries, sometimes very differently. So I've really liked the aspect of the fact that you knew what you were dealing with, but you really had to think a lot and personalize, I guess, the surgical treatment. And I felt like you see a lot of that in trauma. So that's mostly what appealed to me. And fortunately, I had some good people I worked with early on. It's kind of what it is in residency, right? You sort of connect with somebody, and that's the exposure you get, and you sort of like what you see and can see yourself doing it.
Dr. Aiyer, how about yourself?
Yeah, it's a great question. And I went in because of my time at Rothman. I was actually thinking of joints initially, and then I started realizing that I didn't want to be in the hospital for all those periprosthetic infections that I was studying at the time. And I realized I really liked hand and foot and ankle because there was such a diversity of procedure types, and they were mostly outpatient, which is what I also loved. So that was probably what drew me to both of those. And ultimately, I decided on foot and ankle in part because it was a younger field for orthopedics, relatively speaking, and the opportunities across the board to be able to be an educator, be a researcher, be an quote unquote innovator, and be entrepreneurial in sort of mentality. I could kind of fire on all cylinders, which was something that was very important to me as sort of I moved forward in my career. And while obviously I could see myself doing that in other disciplines, I just felt I had a path kind of with foot and ankle that made most sense. I think I also gravitate towards it as someone who used to break dance and do Indian classical dance once upon a time with all of the ankle sprains that I've sustained over the years. Foot and ankle just made sense. But now I will tell you that on the flip side, when my hand partners tell me they've done like 20 some cases in like a day or two, and then meanwhile I'm like on my like umpteen by calc fracture, makes me think I should have gone back and maybe done a little bit more of a trauma fellowship instead. But all that to say, I genuinely, I truly love what I do. And I will say, and I'll share this with anybody, being able to do I think trauma is the crux of what we do, especially now in my practice. Trauma is a lot of what I do, and even with my foot and ankle practice, and being able to, especially for young learners out there listening to this, being able to do trauma is, I think, so important, relative to every other discipline builds on it. So I'll put in a little plug for trauma as someone who does a lot of it on the side, but not nearly as much as that.
No, that's great. I mean, as a hand surgeon, I think you and I have very similar specialties, albeit at the same time very different. But I think both of us, all three of us, do a lot of trauma work, which is both inherent to our specialties and also broadly in terms of our call responsibilities. And I think to be a good foot and ankle surgeon, a good hand surgeon, being good at trauma surgery is central to that, because there's actually quite a lot of diversity of upper and lower extremity trauma that we do in the mix of our kind of elective reconstructive procedures. So it's a great specialty, foot and ankle surgery. And but I do enjoy some of your references. And Dr. Parvizi is an old friend and a research mentor of mine as well. And I'm sure he missed losing you out to foot and ankle surgery over joint surgery. But you're not the first person who worked in his lab that went on to not do joint surgery, just so you know. So, well, let's jump into the article. That was a great discussion on some background. I appreciate all that. So, Dr. Rehman, in your article, you review the role of artificial intelligence in surgical training. And you talk about adaptive learning, surgical simulation, performance improvement, clinical adjuncts. Amongst these, and these are interesting, I read through them, and some of these were intuitive to me, some of them were not. But amongst these, are there any you utilize routinely now or intend to?
Interestingly, I would say it's probably something different now. You know, and in the review paper, what we're trying to do is basically discuss what evidence is there um, for uh, for all of those things. And there's really not a lot. You know, I'm talking about evidence in terms of the scientific literature. Has, for example, adaptive learning shown to improve exam scores, right? Those kind of things. So we don't have tons of evidence yet, but you know, this is a field where you write a paper 1 year and 6 months later, things have changed so much, right? So um, currently, what I would say, what I'm probably seeing right now is the biggest use for artificial intelligence in orthopedic education is probably being like a high quality tutor uh, inside like a self-directed study system, you know, and ideally grounded in sources that you control. So what I mean by that is, I think what we've seen with generative AI is that there's a lot of tutoring capability there, right? And you've seen some programs that are very much geared at education, like Khan Academy, right? Where they've really sort of honed in on that. But then you have people using it on their own, right? So people just go on ChatGPT and try to, you know, learn about something or, um, but when I say tutor, I mean, with certain software now, you can give it the material and say, look, just master this material. So for instance, I'll say what I'm doing now. Like, so this week I asked my orthopedic trauma residency group to, you know, it's their week to learn about tibial plateau fractures, right? So we have a weekly conference topic. So I give them reading material in ROC, right? The AOS ROC. I do lectures from the OTA core curriculum resident lecture series. And I pre-record them. I put them on YouTube, but I say, okay, there's the reading material. There's the lecture material. And then what I'll do is I'll take that material and put it in an LLM. Right now I'm using like Google Notebook LM. And then that smart notebook or digital notebook now just knows those sources. So when I say grounded in sources you control, it's, I think, rather than going to ChatGPT to ask, you know, when you're fixing a bicondylar fracture, what's the best sequence? Do you go medial first? Do you go lateral first? I don't know where it's pulling that if I'm giving it the information and now I ask a question, it's grounded in those sources. But when I say tutor, it means you can say, okay, I take my self-directed learning very seriously. I'm going to ask this to drill me, you know, ask me questions, give me multiple choice questions, make them hard, ask me essay type questions, act like you're, you know, a senior orthopedic trauma surgeon who's having a bad day and is, you know, pimping me out. Go for it, you know? So that's where I think where we at the moment that I think we're getting some traction out of it.
So no, that's great. Thank you. I have many follow-up questions, but we'll take it step by step because there's a lot to unpack there. And, you know, and I'm going to go to Dr. Aiyer next, but it's to me, AI is so big and broad and means so many things to so many people, and it's applied so many different ways. I think it's almost an oversimplification of a relatively complex phenomenon. I think we need to be more specific when we're talking about it in what context. And it seems like you can't have any conversation right now without mentioning it. But it seems like it's a lot of variable, and plus individuals and learners' engagement, understanding, and how to utilize it's also highly variable as well. So Dr. Aiyer, let me ask you. So I'm going to ask you the similar question second about how possibly you are using it and your team's using it at Hopkins, but more broadly, just set the stage a little bit. You know, what do you think are some of the challenges today in training surgical residents? And then, secondly, how could AI play a role as you see it?
Yeah, it's a great question. And I do think that AI is sort of like such a like giant umbrella catch-all for many things. I think, you know, it's like if I get told, you know, just like you put into any LLM for that matter, you know, ChatGPT, Claude, whatever, you know, teach me about ankle fractures, right? And to Dr. Ramon's point, it'll pull from wherever. you don't know. And that's part of the problem, that the amount of data and or data it's pulling from is just so vast. It's basically, it's pulling from scraping the web at large, many of which there may be misinformation in the sources, which is why you get these hallucinations or sort of false positive or false negative type responses. And I even saw someone say recently, hey, like, I tried to use it for research as an example. Recently, I saw this on social media, and it hallucinated references. And I think that in general, the way I like to, and what I start telling the residents, or even some of my partners who are trying to dabble in this, as someone who does regularly, is you have to think of this training tool as not something that knows what you want. It can't read your mind. You have to actually very explicitly tell it what you want it to do, how you want it to function, and what sort of responses you're looking for. And I think when we get more granular with that delineation, it goes to this notion of prompt engineering, such that the more granular we get with what we're looking for, the more likely it probably is to actually give you a response that actually makes sense, that's rooted in data, rooted in references, and so on. Now, I'm not saying that's of all the LLMs, and there are some that are probably better, to be honest. But I tell residents, don't just rely on this alone in isolation. It's not a replacement for your text. It's not a replacement for anything. And just like, like an internal brace is not a replacement for whatever soft tissue reconstruction. It's an augment. And so in the same way, think of using these tools as a way to augment or make more efficient your learning, your day-to-day activity, but it's not purely a replacement for it. So that is where I think it kind of comes to my final point of how do you actually latch onto it, right? And I think for residents and this current generation, they're very technologically savvy. They want to jump onto these things. They're just trying to figure out, like, how do we use it and where, what's appropriate, what's inappropriate, and kind of, because a lot of that is very nebulous at the moment. And even my partners, to finalize things, even my partners are like, I'm not sure I feel comfortable using it. And my general thought is, AI is here to stay, and you need to sort of become, just like the web was this whole thing that people weren't sure if that was going to stay, just like electronic medical records, people weren't sure if that was going to stay, but this is here to stay. So I think you have to embrace it, understand it, and figure out how you yourself can incorporate it. But I think getting residents to latch on is a little bit more easier than maybe some of my kind of more senior partners, as it were.
There's definitely going to be some hesitation in terms of utilizing it, myself included. And maybe I'm starting to become the old man now and don't want to try new things, get off my lawn type of mentality. But as educators and researchers, we really put a lot of emphasis on source knowledge, source references, source documents, right? And what I struggle with AI, and when my trainees use AI, I'm always wondering, where are they getting their sources from? Where's AI getting their sources from that is in turn educating our trainees? That's my concern. And you referenced the issue around research. That's a big issue in terms of references being just produced. We see that all the time. And now there's some apps you can use to kind of read through a paper to make sure that it's not AI generated, which unfortunately is at a very high level that's happening. And the references are the dead giveaway. You can put a reference into PubMed and they don't exist often. So you have to run through that. But how do you control for the sourcing of this? And Dr. Rehman, you talked about it a little bit because you're sourcing it through your own references. And so you're creating your own. You mentioned LLM. That's your
I was talking about, so specifically, I was mentioning Google Notebook LM, which is free. I don't have anything to do with it personally. But with a Google account, anybody can access it. And the base function of it does have some functionality will go out into the web. But the base functionality with that particular software is that it only uses your sources, right? So, if I have put in everything, like I said, for tibial plateau fracture week for my residents into a notebook, I can share it with them. I can create quiz material myself and say, hey, I had the thing, put a quiz together for you. It's there for you. Like, you can share this notebook and use it. But then if I ask it, like, can you tell me which paper Dr. Ilyas wrote, about complications with, with just radius fractures or something like that. Now, whereas ChatGPT might hallucinate and literally come up with a fabricated reference, it's going to say, like, I don't know what you're talking about. It's not in the sources you gave me, right? So, but, and that's very strict to just, if you want to have complete control over the sources, and, as a faculty member, you're sort of using that with your residents, then, you can do that. Or, like I said, if you're a very organized, driven, motivated, self-directed learner, you will come up with those ways. You're going to say, like, I was told I got to read this. I'm going to make sure the material is only focused on this. And, like, I'm going to use it, like Dr. Aiyer said, as an adjunct. And like I said, as a tutor, and keep it sticking with our sources. Obviously, there are, medical ChatGPTs now too, right? So, people are using open evidence if they want to feel more comfortable that the sources are coming from, New England Journal and JAMA and stuff like that. When they ask medical questions, Up to Date's now going to have, or has a ChatGPT where you can ask it questions and it's going to answer it, and it's going to say, here's the up-to-date reference that we're using to back it up. So you're going to see more of that, for the exact, anxiety, that the things you brought up that makes people anxious about it, and where's this coming from?
Let's switch gears a little bit but still obviously talking about artificial intelligence in terms of training. So I think a lot of people, when they think of artificial intelligence, they're thinking of more surgical simulation. They're thinking about doing things on the holodeck of the enterprise, things like that. So, like, is there, and I'm seeing more and more companies, our industry friends, offering surgical simulation tools, which I think initially were more in terms of templating cases, now a little bit more interactive in a surgical setting, in a live surgical setting, or in a preoperative setting in terms of case preparation. Do either of you have any experience with that or thoughts on that, accessibility to it, costs associated with it, et cetera? Dr. Aiyer, do you want to take that one first, or?
Yeah, I'll jump in. There are, at least on the like VR side, as it were, there are a couple of companies that can come to mind, OSO VR and Precision OS, both of which have been around now as simulation training for residents, and they really started catching a lot of fire in and around the time of COVID, because of course access to educational time in the clinic and the OR was obviously very limited or abysmal or minimal for that matter. So the great thing about that is there's a lot of haptic feedback that is a baseline what it incorporates. So whether it be on the anatomy side for medical students, or whether it be on the putting it reaming for a femoral nail, or other sort of disciplines that various industries or various companies in industry have funded effectively, and have partnered and funded the software to be developed, kind of utilizing their sort of data that they have for their instrumentation, so on and so forth. That is really where I think a lot of the simulation is at currently. I envision a scenario, and I'm sure this is actively happening, where the data is being loaded into an AI, algorithm that the companies are sort of developing to be able to make it even more personalized feedback, to the point that Dr. Rehman brought up of almost like, hey, those tutoring. So how someone might be holding their hands to ream for a femur. I'll use that as an example. One person versus the next, you need more individualized feedback than just, oh, hey, you need to raise your hand or so on. But there may be other sort of nuances to the rate at which you're reaming. Oh, hey, are you stopping right at the fracture site? Those types of elements that the AI sort of, kind of the AI augment might actually be able to give further detailed, individualized feedback about. But that's sort of, I think, where at least I'm seeing things going as far as the virtual simulation is maintained. I don't see it as being hey, everyone's going to have like Google glasses or those types of glasses in the OR. And I think that while people are doing that, I don't think that's quite mainstream yet, especially on the resident training side. But I do think that more and more institutions have gravitated towards purchasing these types of VR platforms to give residents an opportunity without kind of outside of going to courses or simulation labs that they may have at their respective institutions.
Yeah, just to build on that, I think we all had our residency interviews recently for prospective classes over the past couple of months. And as we know, in terms of surgical residency, providing surgical training outside of the operating room is an expectation of our accrediting bodies. That could be cadaver labs, that could be surgical simulation labs, surgical arthroscopy simulation, et cetera. That's probably one of the oldest ones that we do in terms of actual simulating, tactile wise. And obviously cadaver probably being the oldest, and then the arthroscopic. It seems like a natural fit to have some AI-driven, VR-delivered surgical simulation. But to me, it seems at this point that there's two things. One, it's not fully formed yet in terms of a package of educational tools or resources as of now. And two, I fear there'll be a cost barrier in terms of this. So Dr. Rehman, any thoughts on that and experience in the space?
Yeah, no, I think, and I apologize for my voice.
You're good.
So, no, I think that, if you think about it, on one hand, we're training people to operate on human beings, on people, right? Shouldn't they really do it in as safe a way as possible? And at a certain level, I would imagine if I was, a lay public person and thinking, you would assume that the person training has had, we're in 2026 now, don't they get all kinds of sophisticated training to learn how to do a surgery? And, you think about it, I mean, they get way more training on actual live people than they do in simulations, right? So we have simulations, but it's not the foundation of what they do. It's like, you do a few exercises, perhaps you have a lab where you do it regularly, but you're operating on people way more, right? So on a certain level, you could see why there could be a need for this. And I think when you think about everything else, right, you want to be a really good musician, you want to be a really good professional athlete. I mean, you practice not in game settings, you practice, right, with coaches, and it's simulated, right? So we don't really do as much of that in surgery as maybe we should. That's another topic. But yeah, you're right. Shouldn't, Dr. Aiyer mentioned stuff like, also VR really proposes it kind of like this, right? Shouldn't we be doing that more often? Especially if surgeons aren't getting enough reps in the operating room on a certain procedure, shouldn't they, get more reps by doing it on a trainer, right? Yeah, it's just technology is not quite there yet. And I'm sure to get there, it's going to be super expensive, and who's paying for that? So those are the realities. That being said, I do think that there's some benefit to things like the VR headsets. I mean, we have a couple of them. I think, like Dr. Aiyer said, they can be really good for instrumentation, I think. Back when I was a resident, if you really wanted to learn, a very instrument-heavy surgery, like a femoral nail, maybe there's lots of sort of like tools you got to swap in and out and stuff like that. Now it's probably, you can learn, rather than looking at the technique guide, right? You get this PDF, or you literally have this book, you would flip through it, and you would try to learn the technique that way. Now, if you do it with the VR, I think they pick it up much more quickly, because even though what you're doing with your hands does not simulate surgery, when you're using those controllers, it doesn't simulate what you do with your hands in the operating room, but you do go through the steps, and there is haptic feedback. So I think it's a step, but in terms of actual simulated surgery, it's definitely not there yet. I mean, as you mentioned, augmented reality, or AR, is kind of another way to sort of have, I guess you could say, imaging, implants, things like that in your field of view while you're doing surgery. And there's probably a little bit more role for that right now, because that's something that, again, if married to implants and instrumentations, that's something industry, may see
Yeah.
value and pitch, putting out for that.
I think it's fair to say, based on both your comments, that it's AI in surgical training is here to stay, but we're probably really early in the curve in terms of really leveraging it and or utilizing it universally and uniformly and its its best potential. I think we're kind of just trying different things, different places. That's kind of been my impression. So that takes me to my last question for the two of you. And this is a research journal, and we're focused on the best evidence. And Dr. Ron already mentioned the evidence is sparse right now on AI and education. So, Dr. I'll ask you this question. So, we need to study this to some extent as well, right? So, any thoughts on how best to study the effectiveness of AI, or where is the gaps in our understanding of this, so that we're doing a good job in terms of developing training tools using AI for surgeons and training?
Yeah, I think it's a great question, and I do agree that this is why this is so important, and why this conversation we're having tonight is super important, because AI is evolving rapidly, probably even faster than we can sort of imagine. And to Dr. Rahman's point earlier, like, the version of whatever LLM you're using yesterday may not be the version that it is today, and the answers may very well have changed. And while that may be good in terms of the ability for it to maybe answer more questions more accurately and with greater precision, the reality is that our ability to study it is limited because it's evolving so quickly. I'll give you a perfect example. We have submitted an article on CPT coding and its ability to kind of recognize that across a few different LLMs, and which one was most accurate versus which wasn't. And we ran it once, and then we ran it, kind of like day zero, and then we ran it again like 30 days later, and things changed. Things change in terms of his ability to do it, probably because of the LLM. It was now not the same, right? It was 1 point whatever or 5 point whatever. So I think that's what makes this difficult. It's not to say we shouldn't be looking to sort of understand this in every facet of a training experience, whether it be on the clinical side with how effective our AI scribes, as an example, something I've been looking into, or and how that helps residents or doesn't, or on the OR side, as we've been discussing already, or then even on the sort of the business side, which is also important for the residents to learn, right, with coding, as we're in part discussing. And so the companies that are forming out there that are trying to solve some of these problems, not rooted in research per se, but rooted in trying to go after sort of the AI gold rush, as I like to call it. The reality is that it will be harder and harder to study this because as mentioned earlier, we have variation in the extent of adoption, right? So people come in people are using it in different ways, people are adopting it at different rates, institutions are using it in different ways. It's not everyone's using the same platforms. So there's a lot of inconsistencies there, which make it hard. So I do think that all these still, even if it's at Rothman or at Temple or at Hopkins or wherever, I still think that institutional experience is still valuable, because we can still learn and kind of try to build upon that. Okay, hey, it didn't work great in this model, maybe we should go elsewhere. But I think the actual studying the questions with such broad sort of generalizability will be hard at large.
Thank you for that. Since our listeners are folks interested in clinical research and this topic in general, I think one important takeaway is this is an area ripe for investigation, ripe for innovation. And I'm hoping that minds who are interested in this and can look at this critically and look at it practically will help us to kind of show us the way how best to leverage artificial intelligence in terms of both, surgical education, which is our focus based on this paper, but also just in general practice, surgical practice, medical practice, and every aspect of it, as you mentioned. So there's a lot to investigate, a lot to innovate in this space. So it's a pretty exciting space, an area I don't understand that well, admittedly, but I know it's here to stay, and I'm open to it and curious to see kind of where we end up with that. So With that, I want to thank you guys both for the discussion and for all your expertise and teaching and all the work that you do at your respective practices. Just making a couple closing remarks here. At SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down. It allows the authors to maintain the ownership of their work. And most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world, with no requirement to purchase access or pay for a subscription. So with that, thank you for joining us. Till next time.